Listen. Thank you, everyone. We're going to start the meeting now. I welcome Mr. Fache. Dr. Fache, sorry. Sorry, I can't say him on the call again. I think he just locked out. Today, we're going to be talking about novel management of ovarian and bowel endometriosis. And on the call, we have renowned obstetrician gynecologist and an advanced endometriotic specialist with us all the way from Brazil in person of Dr. William Kondo. We're equally going to be talking about the robotic assistance arm in OBGYN surgery. And this is going to be taken by Mr. Colin Eck. He's going to be talking to us about robotic assistance arm in obstetrics and gynecological surgery. Mr. Collins is the Chief Commercial Officer at April Medical Robotics. So now I want to hand over to my Vice President, Dr. Olaleye, to give us a welcoming address.
Good evening, everyone, and you're welcome to another episode of AG's webinar. And it's such a pleasure to actually have everyone present here right now. And on behalf of the president of Association of Gynaecological Endoscopic Surgeons of Nigeria, in person of Professor Jude Okohwe, who I'm standing in for right now, I wish to welcome everybody. And I also would like to welcome our wonderful speakers, Dr. William Kondo and Dr. Colin Eke. Dr. Kondo this evening is going to be talking to us about novel management of ovarian and bowel endometriosis. And then also Mr. Colin Eke will talk to us about robotic arm assistance in obs and gynae. I've been opportune to see Dr. Kondo operate during the Mama Africa conference, and I know his dexterity when it comes to handling the bowel as well. And I'm happy our director of training is also on this call. We both experienced that, and we are sure that this evening we're going to have a lot of rich and informative session with Dr. Kondo and Dr. Colin Eke as well. And I would like to thank everyone for joining, and I would advise that we should get our pen and paper ready, because there's going to be a lot of need for us to, get some more information at the end of this and ask very wonderful questions from Dr. Kondo and Dr. Colin Eke as well. Thank you so much. And at this point, I'm going to hand over back to the Director of Training in person of Dr. Ayobode, who is going to introduce our moderator this evening. And after that, we'll get on with this webinar. And I would like to promise all of you that this webinar is going to be straight to the point, and we'll get our facts ready, and there won't be any time wasting. And I look forward to an enriching discussion at the end of the webinar. Thank you, everybody, and you're all welcome. Over to you, sir. Dr. Ayobode.
Thank you very much, my Deputy President, Dr. Laleye. I'm going to briefly introduce our moderator for tonight's webinar in person of Dr. Fatima Abib Adeyemi. Dr. Adeyemi is a distinguished obstetrician gynecologist with extensive experience and commendable track record in both open and minimal access surgery. She owed a fellowship in West African College of Surgeons, and also she owed a diploma from the University of Leeds in the United Kingdom. She has diploma in reproductive health from the Liverpool School of Tropical Medicine. Dr. Abib Adeyemi is a specialist in minimal access surgery and also a member of American Gynae Association of Laparoscopy with many years of experience. She's going to be moderating our webinar tonight. She's the CEO and Director of Pearl Specialist Women Hospital. Welcome with me on board for tonight's webinar, Dr. Abib Adeyemi. Thank you, Dr. Adima. You can take over.
Dr. Ayobode. Welcome, everyone. It's like Dr. Ayobode, Dr. Laleye have already given off all the introduction for the program tonight. Well, I welcome Dr. William Kondo and Dr. Collins Eke for the special program we'll be having tonight. I look forward to, I hope we are all looking forward to learning new things in minimal access surgery today and new techniques in the topics that we are doing. Just to give a profile of the expert surgeons we have on ground, Dr. William Kondo is a renowned Brazilian surgeon with over 3 decades of experience specializing in the management of endometriosis through minimal invasive gynecology surgery. He is a globally recognized top expert endometriosis surgeon with a strong commitment to delivering compassionate, high-quality care to patients. He's led the surgeon and endometriosis specialty unit in many hospitals, and he's directed a team specializing in the management of complex endometriosis cases through minimal invasive technique. He's performed over 5,000 successful surgeries for various forms of endometriosis, including deep infiltrating endometriosis, endometriomas, and involvement of the bladder, diaphragm, bowel, and ureter. He has demonstrated, sorry about that. It's just tough. I'm sorry, that was reading went off. He's demonstrated excellence in surgical techniques that significantly improved patients' quality of life and fertility outcomes. He's taught instructional courses on minimal invasive techniques for endometriosis management, like you already heard. The vice president and our director of director of programs have witnessed live his performance in the Mama Africa conference that was held recently. His skills and expertise spans over expert minimal invasive gynecological surgery, specialized in the surgical excision of endometriomas, proficient in complex endometriosis, and excellent patient care. And is proficient in English, Portuguese, and Spanish. He's not only a guru in surgery, he's also very good with languages. Let's wait and listen to him taking us through the ovarian novel management of ovarian endometriosis and sorry, the new the novel management of the ovarian endometriosis through minimal access surgery. And coming to, I would like to give the profile of the two speakers. Then we wait for the first speakers to talk, after which the second speaker will go ahead as well. Dr. Collins Eke.
Yeah.
Dr. Collins Eke. Sorry? Wait. I think.
No.
I hope I'm not butchering the name. He's presently the Chief Commercial Officer of ACC REA Medical Robotics, and he's a co-founder of Global Consulting LCC Medical Tech and AI and Robotics, and he's held several positions over 3 decades. Sales Director in Minimal Invasive Surgical Solutions between 2013 and 2022, Head of Commercial Business AME between 2016 and December 2022, and Head of CMR Surgical New Business Global. That's the arm assistance that we will be putting us through today. Let's sit back, get our pens ready for a very exciting, engaging session tonight. Dr. William Kondo, I leave the floor to you to start.
Well, thank you very much for the introduction. I hope you are seeing my presentation.
Dr. Williams, sorry, just a minute before you start, sir. Standing as panelists tonight is one of our past presidents, Dr. Olajuwon Alabi. I've seen him. Dr. Juwon Alabi, sir. You're welcome.
Apologies for that, Dr. Juwon.
No, thank you so much. It's okay. We can. I think it might be a good idea for us to ask everybody to mute. Some people are talking, and it's.
Yeah. Thank you, sir. Okay. Also, one of my brother and a renowned endometriosis surgery as well, Dr. Akintobi. I'm dragging him in from Chile to also join Dr. Alabi as one of the panelists tonight. Thank you very much. So we're going to start without wasting time. Over to you, Dr. William Kondo.
Well, thank you very much for the introduction and for the nice invitation. We're gonna discuss today some aspects on ovarian and also bowel endometriosis. Just continue here. Just to start from the beginning, remembering that we have a very important issue on ovarian endometriosis because this is a subtype of disease that affects between 15 to 40% of women with endo. And usually there is a big adherence between the ovaries and the surrounding structures. So, of course,
Sorry,
it's very important.
can you, Dr. Kondo, can you just hold on for a second?
Yeah,
There's
sure.
somebody that is talking. Can you mute yourself, please?
To press those things at times.
Dr. Ọlọ́run Tóba.
I was thinking pé àwọn bọ́ọ̀bù yẹn ò tàn mọ́ ni.
Dr. Ọlọ́run
Oh,
Tóba.
can somebody take him out?
For you as the
Can-
Oh, sorry. So just continue. So there's this big importance because the endometriomas usually are very tubal blockage, anatomical distortions, and also some mechanisms related to inflammatory aspects. Decreased oocyte retrieval rate, reduced embryo and oocyte quality. So there is this importance related to fertility and also pain symptoms in this group of patients. So whenever we talk about endometriomas, we know the features on ultrasound, and we know that the diagnosis may be done by MRI, depending on the experience of the radiologist or the imagenologist. So it's very important to have one very skilled radiologist working with us in order to have a better diagnosis. Also, we know the relationship between severity of deep endo associated with ovarian disease. And this is the most important aspect nowadays. As soon as we diagnose an ovarian endometrioma, it's very important to remember this association because these patients require a good imaging investigation in order to try to define if there is a big amount of deep disease associated or not, because higher percentage of these patients are going to have also deep disease associated. In our experience, in the beginning of our experience, we found like more than 50% of our patients with endometriomas had also bowel disease at the same time. In order to define management, of course, we need to separate patients seeking fertility or treatment for treatment can be different depending on this symptomatology. Of course, for fertility, we have also the possibility of IVF, and for pain, we have the possibility of hormonal treatment, and surgery sometimes can be the best option, both for fertility or for pain, but it depends on specific case. Talking about surgical approaches. Of course, we have a lot of different surgical approaches that we can use. Basically, the most well-known techniques are cystectomy, in which we take the cyst out, but also we can do like vaporization using bipolar or plasma or laser. And more recently, we have the ethanol alcoholization, which technique for some specific case that we're going to discuss. Mainly, the objective of the surgical treatment is fertility preservation for the group of patients who are seeking fertility for sure. And it's very important to evaluate in the pre-op the ovarian reserve in order to define for which patients we're going to indicate surgery and for which patients we're going to indicate maybe oocyte retrieval or IVF directly. Whenever we do ovarian surgery, of course, the cystectomy is the most well-known technique. We're gonna just review some aspects. We move endometrioma, there is the drainage of the cyst, and whenever we open the cyst, we enlarge from the opening, we find the cleavage plane here, and here is the cyst, here is the ovarian parenchyma, and we start the cystectomy in this specific place. Whenever we find exactly the plane, in some cases we can just separate very easily, but it's not usually like this. Sometimes the cystectomy is much more difficult to perform and there is more ovarian damage. That's why it's important to also know the other types of approaches for ovarian endometriomas. After the cystectomy, we need to do hemostasis using bipolar or some hemostatic agents that we know that are available, and also suturing in order to reduce bleeding and also to restore the anatomy of the ovaries. We like for all endometriomas, big endometriomas, to suture the ovary in order to restore the anatomy and have this shape of the ovary at the end of the excision. We need to prevent adhesion. It doesn't matter if you're gonna use like Interseed or some type of gel that we can just place disease at the peritoneum of the ovarian fossa in these patients. Of course, if the patient has no desire for fertility, we can proceed with oophorectomy, which is an option. The new techniques that we have are like using vaporization with CO laser or using plasma jet. So these are techniques in which we just open the ovary. I'm gonna just advance a little bit here. We open the ovary, we wash the inner content. Here we have the probe laser, and we are just turning the inner surface of course, it's a quite slow procedure, but the great benefit is that there is no big infiltration, there is no big damage to the ovarian parenchyma because the laser just penetrates like 1 millimeter or 2 millimeters, and there is no damage across the ovarian cyst wall. So the main objective here is to try to vaporize all the to destroy using the laser the endometrial cells inside the endometrium. This is the final aspect of the vaporization using laser, and it's quite the same thing as using plasma. We don't have a lot of availability of plasma here in Brazil, but next week we're going to test some 2 new devices. I don't have videos of plasma jet vaporization, but basically is the same. And also one important thing is the possibility of doing ethanol sclerotherapy. For some ovarian endometriomas, there are some papers showing that there is not a very big damage into the ovarian function, and some papers showing that still there is some decrease effect alcohol, but compared to ovarian cystectomy, maybe it can preserve better the ovarian function. So this is the way that we do ethanol alcoholization. We just open the cyst. We enlarge up to 5 millimeters the opening just to be able to put inside a Foley catheter. We prefer this silicone Foley because they are transparent. So we put inside the ovary. We just fill with 2-3 cc's of water in order to avoid spillage. Then we just wash a little bit at the cyst in order to remove all the endometrioma's contents and also to measure the amount of alcohol that we need to put without having need to remember that it burn the surrounding structure. So the main objective here is not to have large of the alcohol. So we fill the alcohol and we leave the for 15 minutes. I used to put some water and reduce Trendelenburg during these 15 minutes in order to avoid the contact of. Then we take some. So we do like conferential excision because this is the area where the balloon is in contact with the cyst. So in this area there is less effect of the alcohol on the surface of the cyst. I try to excise this area from the endometrioma. So usually the recommendations for ovarian treatment in the pre-op setting, we usually don't do a clinical treatment for pelvic for infertility, but for pelvic pain, of course, we need to treat this patient before indicating surgery, because some of the patients, this patient will have good pain control using just hormonal treatment. During laparoscopy, we need to decide between conservative procedures. It doesn't matter if it's ablation with laser or plasma jet, or if we're going to do alcoholization, ethanol sclerotherapy. Usually we should use some anti-adhesion in order to reduce adhesion formation in the post-op. And during post-operative treatment for infertility, of course, we will define if the patient is going to seek spontaneous fertility or if she is going to IVF. If she's going to IVF, sometimes we give them GnRH analog if there is especially adenomyosis associated. And for pelvic pain, of course, we keep them on contraceptive pills. This is just to finish the guidelines of ESGE for the ovarian endometriomas. Whenever we have endometriomas and pain, we can use either cystectomy or laser vaporization because these are the techniques that have the best result. Maybe in long term, cystectomy is better than laserization. And also, we need to remember that there is this problem of doing endometrioma treatment, surgical treatment for ovarian endometrioma, which is the reduction of the ovarian reserve. For fertility, we should remember that doing surgery for endometrioma may increase the chance of natural pregnancy in infertile patients. But if there is if the patient has symptoms, of course, we need to consider the possibility of doing surgery if the patient wants to conceive. But also, it's very important to remember that we can reduce the ovarian reserve. So whenever there is endometrioma, we need to focus on the pre-op investigation of the ovarian reserve in order to decide which patient is going to have benefit from surgery and which one need to do IVF. If there is indication for IVF, if we're going to just retrieve oocyte having endometrioma, it's very important to do antibiotic prophylaxis because it increases the risk of abscess. There is no need for absolute indication of surgery before the oocyte retrieval or besides the embryo transfer. So there are some patients that will be pregnant with IVF without the need for surgery, but some patients who are very symptomatic, maybe some of them may have indication for surgical treatment, even if they're or planning IVF. And in some specific cases, if there is some difficulties in having follicles or access for the follicles, sometimes we consider surgery. So these are the main indications of the estuary for also for from a fertility aspect and also for pain management. And of course, these patients, we need to remember to discuss with them if they're not seeking fertility at that moment, that there is the possibility of fertility preservation. Endometriosis and especially endometrioma are very dangerous for fertility. So always we need to discuss with these patients the possibility of fertility preservation. As take-home message for endometriomas management, of course, one of the most important aspects of endometriomas is to remember that there is a big association from endometrioma and deep disease. We're going to discuss in the next presentation bowel disease. In our experience, we have more or less 50% of patients having endometrioma who also have bowel disease. So usually there is this association, and for the surgical management, of course, this is one of the most important concepts to be remembered. We have some controversies regarding fertility treatment because some of these patients can go directly to IVF, some of them be benefit directly. Some of them need to retrieve oocytes or preserve embryos before surgery. This depends on patient's age and especially ovarian reserve and the diameter and the presence of bilateral endometriomas or not, because as soon as surgery, if the surgery can reduce the ovarian reserve in a significant manner, of course, we need to preserve fertility before the surgical procedure, even if the patient is very symptomatic in terms of pain. And for the pain aspect, surgical treatment usually improves pain, depends on surgical technique and experience, because we need to try to treat the disease without damaging too much the ovary. Always remember that there is this negative effect on the ovarian reserve, so we need to select very well the patients that are going to go for surgery, and always discuss if there is any benefit of preserving fertility before the surgical procedure. And for post-op follow-up, very important to try to reduce the risk of recurrence using some medication if the patient is not seeking fertility at that moment. So always try to individualize the treatment because this is the main goal. Whenever we talk about bowel disease, also very important to do the preoperative workup in order to define the amount of disease, the location of the implants and nodules. There are a lot of papers showing that we can do this workup using either ultrasound or MRI. We have our very experienced radiologist who works with us for the last like 15, 20 years. We have been improving our pre-op diagnosis even now. For the last 2 years, what he could improve was the diagnosis of nerve infiltration by transvaginal ultrasound. We are able now to check the proximity with the sacral roots and also hypogastric nerves, and all this we couldn't even in his hands like 3 years ago. So we are always trying to improve our uh, uh, also investigation in the pre-op and surgical treatment for these patients. It's very important to remember that uh, not just but also disease is based on clinical matter exam to indicate the surgery because of patient symptomology, not based on imaging exam. Rate because of or fertility, and especially for infertility, there are a lot of questions that we need to answer before indicating just surgery in order to improve fertility. Also very important to know that there is a good correlationship, a good correlation between the pre-op diagnosis and the intraoperative findings. Of course, it depends on the good connection between the radiologist and the gynecologist and the surgeon. There are different surgical techniques to discuss, but basically we have segmental bowel excision and conservative procedures that will be selected according to some aspects. For shaving or discoid, usually we indicate for unique nodules centimeter in general. And for segmental, big lesions more than 3-4 centimeters and multiple nodules, of course, these patients are going to require segmental bowel excision. But it's very important that we plan this in the pre-op, this imaging exam, but on intraoperative findings, the surgeon experience to if it's really what we're going to do, because there are some times that we try to do a Discord, or sometimes that we plan like a segmental and we can do like shaving or discoid. So the surgeon needs to know all the different techniques in order to select which is the best for each patient at the moment of the surgical procedure. We are going to talk about bowel disease, so I'm gonna jump the basic stuffs. Shaving. This is the basic technique. We have a very small nodule here at the bowel. So if the nodule is very small, we just cut a little bit the muscle layer of the rectum. We try to excise the nodule. We have the defect here, and we're going to repair the defect using sutures. We place either continuous or separated sutures in order to reconstruct the bowel wall. So this is the final aspect. Also here, sigmoid, small nodule, like 1 centimeter. We prepare a little bit the mesosigmoid using harmonic energy. Then we shave. Also, usually when we shave for shaving, we try to shave, if it's possible, using cold scissors. If we're going to shave for discoid, we usually use energy because we're going to take out that wall. So we finish shaving and we have the defect. Always try to suture in a transverse way in order not to have stenosis. So at the end of the reconstruction, we're going to have this aspect, suturing in transverse. Sometimes we go a little bit deeper. Here is the nodule. We're going to open a little bit. We see that we open just a little mucosa here, but there is no problem. If we are planning a shaving, we can just suture. We just close the mucosa and then we do the cerebromuscular reinforcement the repair of the bowel wall. In this case, we can see that the nodule is very small. We start shaving thinking that it was very superficial, but the thickness of the ball is not that thick, of course, so we easily sometimes open. Whenever we open the bowel, we suture in 2 layers. So this is the first layer, and then we do a second layer, just reinforcing ceromuscular. And in this way, we close completely the defect. For small nodules less than 3 centimeter, also we can apply different techniques such as the linear stapler. This is not the technique that we use a lot. There are some groups here in Brazil who use much more than us, but we can use the linear stapler just behind the nodule in order to try to excise completely the nodule using this technique. Also, if we have vaginal opening, we can enter with the stapler transvaginally and take out the anterior rectal wall using this linear stapler. There are some groups here in Brazil, as my good friend Guilherme Caran, who does this type of excision for big nodules up to 3 centimeters, and then he pass a probe here not to have stenosis and use the linear stapler 1, 2, 3 loads in order to excise completely the nodule. Of course, there is a long line of staplers, staple line. We don't use this type of excision. We prefer to do discoid excision. When we compare shaving and discoid, the main difference is the reconstruction. When we reconstruct using shaving, we just repair with suture. With the discoid, we just cut and repair with the stapler. So this is the main difference. We use the circular stapler in order to do the discoid excision. Nowadays, we have the 3 staple lines. Circular staplers, which increase a little bit of this type of resection. The basic steps are: we prepare laterally the mesorectum. So here we are in the left side, then the right side. We prepare very close to the bowel and try to define the lateral limits and proximal and distal limits of the nodule. Whenever we have these limits, we start shaving. Sorry. Just I think I lost these videos. Well, we start shaving. So here we are shaving the anterior wall of the rectum with the harmonic, and we take out especially the fibrotic tissue, because whenever we take out, we have just the soft wall of the rectum. The softer is the rectum, the bigger is the amount of rectum that we can put inside the circular stapler. So we have the shaved area here. We're going to pass suture in order to use the suture to guide the anterior rectal wall inside the stapler. So we advance the stapler transanally. This is the circular stapler. We just advance. We open a little bit the stapler and use this suture in order to guide this area into the circular stapler opening. Whenever we do this anteriorization of the stapler, we just put the area to be excised inside, and then we fire the stapler, and we have the instantaneously the anastomosis in healthy tissue. So this is the technique of the circular stapler. And also we can do it for very big nodules. We have some quite experience for this type of lesions. There is this big defect, a very low lesion. Sometimes we try to do double discoid excision, which is the double application of a circular stapler. So the other option would be a segmental bowel excision. But for very low anastomosis, we know that the risk of complications is a little bit higher. That's why, if there is possibility, we try to do double discoid excision. So here we're just trying to put in one circular stapler, but it's a very big area. So we are advancing. We know that there is a defect to be excised. So we staple the first circular stapler. Then we put another suture and we fire the second one. So we are advancing a second stapler and we have the anastomosis in healthy tissue here. So this is a possibility in order to avoid, this is the specimen, in order to avoid the use of segmental bowel excision. And for big nodules, we use the segmental bowel excision technique, which is the conventional one. The difference is that we go very close from the bowel. We do a transmesorectal approach. So we prepare completely the area to be excised. We see here the nodule. So we are preparing the mesorectum just laterally and posteriorly. And whenever we reach the area, we just advance trocar and the linear stapler. We use the funny steel incision for extraction. So we staple from the anterior to posterior in a vertical way. Here is the stapling. And we bring the loop through a funny steel incision in order to put inside the anvil. And we come back to the laparoscopic view and do the anastomosis. This is the traditional way of doing segmental bowel excision. Nowadays, we are trying to use, we just reinforce the crossing of staple lines from the circular and the linear, and then we finish the procedure. Nowadays, we have the possibility of doing nose procedures. This is just the transvaginal way of extraction, doing the purse string suture inside the vagina, which is very difficult because very difficult to bring outside the bowel, but it's possible. What we have been doing since last August, I would say, when there is hysterectomy, we staple transvaginally the distal stump. Then we have the bowel here, the proximal, which is having the nodule. Then we place a bag. We place the anvil inside. We open the bowel inside the abdomen. We put the specimens inside the bag in order to try to minimize contamination. Of course, we're opening the bowel inside the abdomen, so we have some degree of contamination. We do the purse string suturing laparoscopically. We put the anvil inside, we just tie, and we do the anastomosis in this way. For these specific cases, we don't change our pre-op and post-op management. We don't use antibiotics therapy for this type of situation, even opening the bowel inside the abdomen. And the other possibility is when there is no vaginal opening or hysterectomy, we do the transrectal nose. We open the distal part of the bowel. So the nodule is here at the proximal area. We're opening the distal end. We try to pass like a plastic tube in order to try to minimize contamination during the anvil introduction because we pass the anvil inside this plastic tube. We open the proximal end. We do the purse string at the proximal end. We put the anvil inside. We close the proximal end. We extract all the specimens transrectally. We see that the specimens are here. We're going to extract all this transrectally. And then we do a purse string distally. we enter with the stapler and the spike just exit here. We are advancing the circular stapler, we advance the spike, we tie around the spike, and we do the anastomosis from one side to other side, and we have this circular anastomosis without the need for using the linear stapler in these cases. These are the main, the most important principles of bowel surgery. So we try to do to be as economical as possible. We prefer to do transmesorectal then total mesorectal. We preserve vascularization. We minimize contamination. Of course, with no procedure, we open the bowel inside, but of course, it's important to try to minimize contamination. If we're going to do abdominal incision, we try to protect the abdominal wall using retractors. Always important to have a tension-free anastomosis to reinforce cross of staple lines and to do at the end air leak test in order to check for some gas. Here we are doing the evaluation of the vascularization with ICG. We don't use it routinely, but of course nowadays, as we have the possibility, it's very important to know and to try to apply as much as we can, because lead us to know that the anastomosis is very well vascularized. And the safety tests, of course, it's important. If there is bubble leak, we need to that area. So in this case, we just put stitches in order to reinforce and repeat the test after the suturing. So, continuing our principles, we evaluate perfusion at the end of the procedure. We do the safety test. If there is a requirement, we reinforce the suture line. We usually don't use drain, but it's a possibility. And of course, if there is any doubt, according to the anastomosis, either we redo the anastomosis or we do a protective stoma. So as final considerations, it's very important to do an adequate apposition of the tissue for bowel surgery. We need good perfusion. We need to minimize trauma. We need tension-free anastomosis, and it's very important to reduce contamination. Always for the patient, the less invasive, the better. So that's why we need to tailor our surgical procedures in order to find which one is the better for each patient. So our table of indications nowadays is for less than 1-2 centimeters, we can do sometimes shaving. For less than 3 centimeter, we maybe can do discoid. For lesions up to 4.5 centimeters low and mid rectum, sometimes we do double discoid. And for segmental, which are the big lesions or multiple lesions, nowadays we try to do always a transvaginal or transrectal nose, depending on the presence of vaginal infiltration or hysterectomy. We do transvaginal. If there is no vaginal opening, we do transrectal. At the end, we need to individualize each patient and each surgery for each patient. There is a precise indication for surgical procedures and these different surgical techniques. That's why it's very important to know these techniques in order to apply the best one for each patient. Thank you very much for the invitation. These are some of our online educational activities in this platform. We have some courses also in English, and invite you for our next Congress, which is going to be the 5th edition. It's going to be June 2027. The next year will be the first year that we will have English translation, because up to today it was Portuguese and Spanish, but this year we just test some English translation and how it worked. For the next year, we're planning the Congress with English translation. Thank you very much for your attention.
Thank you very much, Dr. Kondo, William Kondo. You've taken us through the Ovarian technique and the Bowel management in endometriosis. And that was a very interesting one. I hope everybody have their questions ready. He's giving us the new technique, talking about vaporization using laser, vaporization using plasma jet. Then he spoke about ethanol sclerotherapy and recommendation on pre-op, CT and pain. And for the Bowel section, also mentioned the different types of techniques, shaving, discoid, segmental, and they emphasized that a very good surgeon should know all the techniques so as to make the right technique, the right choice of technique for the form of endometriosis found in the bowel on entry, intra-ops. So we look forward to your questions. Please jot them down while Dr. Colin Ake take us through the arm session. And before then, I thank you, Dr. Ayombode, for saving me. I apologize to former president and the panelists for making a big group there at the beginning. Thank you. Dr. Colin Ake, I think you can take the floor now. The floor is yours.
Thank you very much indeed. Very good presentation, Mr. Pondu. Thank you for your expertise. Just for the record, I'm not a doctor actually, but thank you for the credit. But I'm not. I'm hailing from the commercialization side of the industry that we are obviously both working in, but from a different side. I've been in medical device technologies for 35 years now and counting. And for the last 20 years, I've been in robotic technologies or advanced minimal invasive surgery. So I think I'm going to share a few slides. I've got 6 or 7 slides from one presentation. Then what I'll do is I'll close that one down and open up another one. And I just want to share a few more slides on a different presentation I've got. And I'm really here to talk about, well, first and foremost, a new technology that is going to be arriving in your country very, very soon. And probably many other countries actually in your region, within your continent, and probably down into Latin America as well, actually, which will be quite interesting. But I work with many different companies, but one of the key drivers right now is to look at minimal invasive surgery. Okay, I've sold some very big, expensive robotics. I've worked for Intuitive Surgical. I've headed up commercial business for CMR Surgical, which is a UK robot company. And I've consulted with all the companies, all the Chinese companies coming into the market. Some have already arrived and many others. And one of the takeaways over 20 years is it's very clear that it's totally ridiculous, the price points of surgical robotics. It's like a private members club. You know, you are very fortunate as a hospital to be able to get one in any country around the world. To give you a little bit of a flavor, where I'm based in the UK, we have now 210 Da Vinci robots, okay, which sounds a lot, but out of those 210, at least 200 of those would not exist unless it was for charitable money, okay, charities that raise money to buy the robot that costs £1.5 million just to own it. And then when you plug it in and you got to pay 150,000 a year to service it, whether you use it or you don't. And when you do use it, it costs 4 to 5 times the cost of laparoscopy. So it's a very expensive tool for some benefits. Of course, there are some benefits. Clinical benefits are yet to be really proven out, unless you're talking probably a prostatectomy. You know, there is, and I'll show you some statistics in a minute. But we firmly believe that the way to approach the democratization across the world to advance laparoscopic is to bring out laparoscopic version 2. And I'll tell you what I mean by that, okay? But remember, along some of my slides, there's the 3 main advantages of having a surgical robot in your practice, whether it's gynecological, it's ovarian, it's bowel management, it's urology, whatever it may be, is to have dexterity, is to have good vision, control. Okay, they're the 3 things. And dexterity, I mean by having 7 degrees of freedom, having like your human wrists miniaturized inside the patient. And that is a big advantage because laparoscopy, I mean, he's Kondo, an expert in his field, but it's a very difficult skill to master, laparoscopic. So we want to try to make the next generation of laparoscopic surgery. So I'm just going to share my screen if I may, and please tell me if you can see my file. Can you see my screen?
Yes, please.
Yeah, it's come through. Has it? It's visible. Yeah, just for the record, we've had a bit of a heat wave here in the UK, which we're not used to, and there's severe thunderstorms. So if I suddenly disappear off the face of the earth, I'm okay. It's just my Wi-Fi crashed. Just that. But anyway, we'll go. We want to develop a system that allows flexibility in terms of the operating room. So we've come up with a plan to launch a surgical robotic assistant, first and foremost, for all MIS surgery. But in particular, we're talking this evening from a GYN perspective. We want to empower the healthcare with robotics, but not at a crazy, unaffordable price. So in the picture there, this is our first. It is a non-motorized passive arm which holds the camera. Okay, it holds the camera just like one of your surgical assistants would do. It's dead steady. It doesn't move. It's fully maneuverable by pressing a button, and the surgeon can reposition it and then press it again and go back to doing the surgery. So there are advantages there is it will potentially free up a surgical assistant, first and foremost. But you're getting that control, which is one of the 3 common denominators I mentioned earlier. The main problem right now is personnel bottlenecks. I'm not over familiar what it's like in your country, but there's a massive shortage of doctors today. The company I'm referring to is based in Poland, hence why it's referenced Poland on the screen. But the average age of the doctors in Poland is 57. It's pretty high, it's a heavy workload, there's a lot of stress, and we are predicting a big shortage in surgical trained personnel over the next sort of 5 to 10 years. And that's a big issue. Another example here in the if you're unfortunate to be taken into hospital anywhere around the UK at 2 o'clock in the morning, and you have a hot cholecystectomy or your appendix is burst, very, very difficult with the new working initiatives and rights, etc., across the EU for a surgeon, a consultant to find somebody who knows what they're doing at 2 o'clock in the morning to help. So here comes another potential benefit of having a robotic arm that replaces a surgical assistant from holding the camera perspective, and also potentially putting an additional arm, park it. That is another potential benefit. And in fact, we're just about to kick off a scientific study out of the largest university hospital in Brussels, starting in 3 weeks, I think the professor there is going to be doing nearly 800 cases under the scientific program per year. 50% of it will be ambulatory and 50% will be emergency theatres to see what benefits this will bring clinically from the surgical perspective and, of course, the hospital perspective, but potentially as well from the patient perspective, being able to operate autonomously where the needs must, and also in the private sector as well. There is a big advantage to have some degree of autonomous surgery in terms of working on their own. The problem with existing medical robotics, I've told you, they're big, they're bulky, large, very expensive. They set up time is long, but it's more to do with the economics. The economics does not work in developed or developing regions around the world. It really doesn't, unless you're in the USA, but that's a bit of an anomaly because that is a totally private market where the rest of the world doesn't have that advantage. So our solution, it's easy to set up, very small footprint. You can have one arm, you can have two, you can have three, you can have four. If you have something like a lower anterior resection, for example, where you actually require some double retraction, you can do that. You can move them around any operating room you want. They're very, very small in comparison. Access to ambulatory and office surgery as well. And the surgeon's always at the patient's side, so there's no other potential risks the other side of the room, and the head is stuck into a surgeon console. The cost is going to be considerably lower. Okay, we are talking here, the capital equipment below 100,000. Well, that's going to be if you have up to sort of 3 or 4 arms. So you can do the mathematics per singular arm. It's going to be very affordable. In Europe, it takes it way below the legal amount from a legal tender perspective. Very low disposable costs, and we are developing the 2nd and 3rd generation of arms very, very soon. I'll come on to that in a minute. It's going to have AI. Everybody talks about AI. What we mean by AI is on our 2nd and our 3rd generation arms, which I'll show you a picture of those. They'll be slightly different because at the distal part of the arm, it will have either 4 degrees of freedom or there will be a 7 degree of freedom version, which is identical to a Da Vinci, if everybody's familiar with the big surgical robot. And from an AI perspective, we are training the arm to follow the tips of the surgeon's instruments automatically. So no intervention from the surgeon touching the camera, it will automatically follow it. Wherever the tips of the surgeon's instruments go, the camera will follow it automatically. At the minute, you can interface it with a direct manual, pressing the button, joystick, remote control with force feedback. There's a lot of developments happening along this way, but I'll come on to something which is going to be super exciting in just one moment. But here are the 3 arms. This is the one on the left. P stands for passive, so zero gravity arm. Zero gravity is very important for when I discuss with you in about 5 minutes about the surgical instruments that we are developing as well, which I'll come back to that point, but remember the zero gravity is very, very important. So for the camera or retracting an instrument, the 4, it will have 4 degrees of freedom, and 7 will have 7. And you can see along the line, they get a little bit more robust, slightly bigger, because there's a lot more electronics running through. But still, they are very much designed on the human arm, where you have a shoulder, elbow, and a wrist, and you've got full dexterity as well. So this will give a lot of advancements to laparoscopic surgery without having the big cost of a full system. There's a few details there. I won't read them out, but you can just have a few seconds to look at the screen. There's obviously some more features as we go along our pipeline of development. The 4 will have CE mark within the next 3 to 4 months. The 7 will probably take about 2 to 3 months after that. But the current system that we are launching and have already launched in many countries in Europe, and we're going into some countries outside of Europe as well. We're moving down the 510K route for the US, so that will only take us 90 days. That already is CE MDR'd, is the Avros-P. AI-supported robots, I've sort of touched on that, but there will be a lot of data being collected, useful data, not meaningless data, a lot of data that is going to be fed into the system to connect it again also to hospital record systems, etc., as you would expect. But I think the main point of the AI is going to be clinical benefit intraoperatively, where, for example, the camera will automatically follow the tips of the instrument. And then we'll have other things like no-fly zones coming into play when it recognizes some anatomy that it is trained not to go near. It will then flag up a warning to the surgeon. But all that takes a bit of time because you've got to feed the amount of data in to the systems. But these are our plans as we move forward. Right now, it's it's lightweight, it's safe, it's very cost effective. There's modular hardware with drives, links, base effectors, modular software, operating software systems, specific apps, etc., etc. It's going to be very modular, where we can build things where we feel mutually that there's going to be benefit to surgeons, to hospitals alike. Just a few of the use cases that we're taking this into. Of course, we're talking about gynecological surgery here. It's available for any laparoscopic minimal invasive surgery. We're developing a biopsy robot. Dentistry as well, there's a lot of interest. There's even interest in the veterinary markets. We're looking into the development of a navigation robot in brain and spine, spine and brain surgery. And other potential applications as we move forward. That's because it has the modular effect. I think everyone's probably seen these statistics for a long time now. About 20 million and growing soft tissue surgeries per year. Laparoscopic is near enough half of those. Robotic surgery, which is Da Vinci and all the other incumbents, is probably slightly less than 10%. Actually, it's riding between 8 to 9%. But by 2030, laparoscopic will reach 60%, and robotic around 20% is the forecast right now. I think this speaks volumes. This comparison chart, in terms of laparoscopy, which I'm sure everybody or most people on this call are very experienced and are trained to do. Soft tissue robots has a few ticks, but it also has a few crosses along the list. But where we see this is more robotic-assisted laparoscopic. Okay, and there's a big key differentiator there, because we want to still keep within minimally invasive. We want the preparation time to be low. We want the surgeon to be close to the patient. We want the surgeon to be in full control. Stable visualization, which is very, very key, which you don't always get with laparoscopic. We want it to be ergonomic, learning curve to be very easy, and obviously, quite importantly, we want it to be cost efficient as well. Here's just some of the current companies that are within the robotic market. I'll just skip through some of these. Now, there was another presentation, so if I just want to share a couple of slides on something else, if I may. Okay. Okay, can you see that screen?
Yes, please.
Yeah, okay. So I'll skip through this very quick because some of these are repeating, but there's one very important, and I think you'll find quite exciting thing that we're going to be launching not too far into 2027, which works perfectly and harmoniously with our robotic arms. So here's a bit of a better picture here. In terms of our current system here, you can see more than one. The arms aren't actually attached to the table. That's just a visual effect. They sit on their own little pods, if you like, and can be moved around the operating theatre. But you can see there, it doesn't take up a lot of space. It doesn't interfere. They can be positioned anywhere. They have great reach as well. So if a surgeon prefers to stand on one side of the table, that's okay, because the arms can go the opposite side and they can reach across. That's not an issue. So very modular. But this is the thing I want to talk to you about. So the Avros P I've discussed is available, and Slotan in Nigeria are our full registered distributor for everything that you see on this screen. Okay, just for the record. Now, what we are calling next, and this is where the advanced laparoscopic version 2 comes into play. We are going to develop, and we've already got a prototype finished form. We are going to develop the dexterity, which is one of the first 3 components of robotics I mentioned at the beginning of this presentation, having the 7 degrees of freedom, like your human wrist. We are putting that at the end of a laparoscopic instrument. We all know what a laparoscopic instrument looks like. We know what diameters they come in. We know the functional features, whether they go up or down or left or right or in and out. That's all they do. Okay. We are going to have a identical Da Vinci tip at the end of a laparoscopic instrument. Now, there's 1 or 2 companies that already have already developed such a device. However, they developed it where it's so heavy, super difficult to use, actually not intuitive at all. But more importantly, it's super expensive. So what we've developed is a very lightweight version. And going back to the point I mentioned to you about our arms having gravity compensation. So you put the 2 instruments down, one of our Avros P arms, one on the left and one on the right. It's literally like holding a feather because it's gravity compensated. So it actually feels lighter than a standard laparoscopic instrument. But we will have 7 degrees of freedom, which gives you the full robotic dexterity at the tip. But we're going to do it at the same cost as standard laparoscopic. And we think that's going to be a game changer. And when you have that along with a 7-degree version or a 4-degree version on the camera arm, which automatically follows the tips of those instruments, all the surgeons are really missing is a chair. Well, we have a plan for that. We're going to develop the first laparoscopic chair that surgeons can sit or semi-sit, semi-stand, if that's what they desire. If they don't, then fine. You don't need to use it. They just stand and carry on like they do day in, day out. So we're going to do that at a cost that is going to be a game changer when it comes to having the ability to have advanced minimally invasive surgery. And all countries, all continents around the world, there will no longer be a sort of private members club association to do with surgical robots, because we believe it's now time to develop laparoscopic version 2. And that we think is going to be exceedingly exciting. What you do see on the screen, though, is something that we've got under development, which is called Dragon at the moment. And that is a console robot. Now, that's going to be 2.5, 3 years down the line. Okay. What you see is like a mini version of a Da Vinci, and those 3 arms are 3 Avros A7 arms, as you would expect to have 7 degrees. But we're not necessarily going to be doing this and launching like all the other robot companies in the world, we're going to have very specific procedure types. And we're probably going to start in cardiac, actually, and things like atrial fibrillation, which doesn't really get touched by any surgical robot today, and other very specific procedure types, because we believe sincerely that the first two, the robotic arms that hold cameras and instruments, and then added on to our wristed fully dexterity instruments, is going to be what really moves the needle along for, as we know today, laparoscopic surgery. And the final thing to mention is when it comes to gynecological surgery, for example, we are at the phase now where we are wanting to develop something like a uterine manipulator. You know, that a uterine manipulator is used in a huge percentage of gynecological surgeries. And right now, as everybody knows, a surgical assistant has to sit in between the patient's legs for the duration of the procedure, move it up, down, left, or right. Well, to us, that seems a waste of resource. So we would have one of our mechanical arms, which could actually be the uterine manipulator, and that can then be activated by a joystick at the bedside. And that person who would be there ordinarily can go and do something else, or they can assist in a different way. And we think that is going to be, a small factor, but I think it will be nevertheless something which would be very interesting. And there basically is just a few more descriptions about our portfolio. But right now, as I say, through Slow Term, we are launching Avros P. The 4 and the 7 will be coming along the line very soon. And the Wrist-X is the instrumentation, which will be handheld laparoscopic, but with Da Vinci-like instruments, if everybody's familiar with the Da Vinci. And I think really that I don't want to take up any more of your valuable time on a Sunday evening, is roughly where we are.
Thank you, Mr. Colin-Seki. I think that is better now.
Yes, no problem.
For taking us through that new invention in laparoscopics. It's like aiding the laparoscopic surgery. I used to know fascius. Fascius is the heavy arm from the floor that you have to move around. Now seeing Avros it's really motivating, because Avros, from what I'm looking at, comparing it to fascius, is like having a mobile will I say point of care?
Yeah.
And when you have to go and carry a big, heavy load. So that's a very good one. So
well, the other advantage of, did you say Versius, the UK robot? Is that?
Yeah.
Yeah,
yes,
I used to work for CMR Surgical.
Yes.
So I'm very familiar with that system. The problem with CMR and all these companies is, they are, they're very expensive. Okay, and and of course you have to use all of their instruments with their closed system and their vision equipment. So everything has to change. With the Avros systems, right now, of course, we're launching and then developing our own instruments, as I mentioned. But for now, the camera is, you use whatever camera system you currently use in the hospital. So you don't need to change everything. You'll currently be using your own laparoscopic instruments that you've agreed to purchase as a hospital. So very little has to change. And when we do have our instruments, well, you might find that for some very easy procedures, you don't need to have 7 degrees of freedom. Okay. And maybe for the more difficult parts, you do. So we want to be more flexible rather than saying, use our robot, you can't use anything else. That's not the way forward. Not in the economic issues around the world right now in every country.
Yes. And it would be very nice having your surgery and not having a third person at the bottom of the table manipulating, just like you said, just pressing on the button. And the uterus.
And we're going to do, even for ENT. I know this isn't about ENT, but if you look at ENT surgery, you need to have gags. Well, we'll put one and attach it to the arm so somebody doesn't have to sit there for like 2 hours or 3 hours retracting the mouth space. So there's many things that we can develop. And if there's anybody on this call that's got some great ideas, we're a very open company. We're happy to work with people and experts in their field. So, the door's always open with any good ideas. But yeah.
Yeah, that's great. Thank you. We've come to the end of the presentations and now to the question segment. And from the panelists, do you have anything to say before we go to the questions, please? Dr. Labi, Professor Ezekiel? Or we take the questions?
And Dr. Akintobi as well.
Dr. Akintobi, yes, thank you. You dragged him on board.
Hello, good evening, everyone. It's been an interesting session. Thank you very much for bringing me on board at the late hour. But I enjoyed every bit of the presentation, right from Dr. Kondo's presentation on endometriosis, being does endometriosis surgery practically every day. I could relate with his presentation very well. And that brings us to the issue of the pelvic surgeon, where we are looking at this possibility where a gynecologist has the requisite skill to be able to handle any pelvic pathology, be it involving the bowel or any other pelvic organs. And we could see how they're able to manage their cases. So I just want to ask Dr. Kondo, with his vast experience dealing with bowel surgery, are there situations where you've had some challenging cases? And then what is the risk of failed anastomosis in most of your resections? And then when these do happen, how do you address them eventually? So that's for Dr. Kondo. I'm going to Mr. Collins. It's quite promising to see that technology is evolving. Minimal access surgery is one specialty that depends so much on technology. And seeing that people who are in the industry are also considering the term of finances when it has to do with upgrading to robotics, and they are bringing up solutions that could help out. It's quite heartwarming. And then you can, of course, for most of us here who are minimal access surgeons, we do know that that assistance in being able to focus the camera where you want it at the right time is one of the greatest challenges that every minimal access surgeons get to face. And when you have this kind of robotic arm that can help you to do it the way you want, I believe life will become much easier. But the downside of this is that eventually we might start having the new set of minimal access surgeons who will not know how to manipulate cameras. So that could be the downside. But it's quite encouraging and promising. And then getting to know that you intend to actually bring this to Nigerian markets is heartwarming, but we'll try and appeal to you that Nigerian markets is a big market, yes, but economically we are not as viable as that of Europe. So whatever you can do to have as many people to get on board in terms of lowering the cost and maintenance, and we don't know what the durability is going to be like. Is it something you need to change after a couple of years, or something that will require some maintenance fee as well? So you can see that. So by and large, it's a great time. Thank you very much. Thank you.
Thank you, Dr. Toby. Dr. Alabi, do you have anything to add? Professor Zinking?
We have Dr. Christian Alabi.
Professor Jude.
Yeah, that's something.
He's no more on the call.
See our very Mr. Justin as well. Whether they have any words for everybody in the call. It's evening. I think my president has come on board. Yeah, anyone? Mr. Bolarijo Lassa.
Yeah, President. I don't know if he has anything.
Dr. Christian Alabi is still on the call. Yes. I don't know whether he has something to add. Any question from Mr. Polo Williams or Dr. Polo Williams or Mr. Collins.
Any question from the floor?
Yeah, hello.
Oh, I was going to say I can see one of our eminent senior colleagues.
Yeah, Dr. Dewale and
Yeah.
Dr. their hands are up.
I can't see any hand up, but Dr. Bola wants to talk. Dr. Ola wants to talk, please. Okay, I can see their hands up now. Can
Thank
Dr.
you.
Ola go on, please?
Yeah, thank you very much for an interesting set of lectures. I am very grateful that we had such eminent speakers. My observation, or rather question, is to Mr. Collins about the assistance and what are the relevance of these to training. I think Dr. Akitobi mentioned this in the last two sentences. When we have so much artificial intelligence or robotic assistance, as you say, how are we going to train the next generation? I've been a trainer for over 20 years, and I think one of the important things about endoscopic surgery is working within a team. And if I exclude my team by employing robots to assist for me, to retract for me, so what about the interaction between my senior registrar, who is experienced, interaction with even the junior trainee during surgery, and the fact my obligation to train them? I think you know what I'm talking about, because we are on a slippery slope where we get first assistant and second assistants are robots. What happens to our trainees? When are they going to finish training? Training are going to be 10 years, 12 years instead of 6, 7.
Excuse me. No, I think that's a very valid question. And actually, it's a question for the whole robotics industry, actually. Whether you're referring to the system I presented or you're talking about a Da Vinci surgery where the surgeon sits on his own, and he's in his own world, his or her own world. And a lot of the time they end up doing everything because you can have robotic suction irrigators and everything. So, but in terms of our perspective on that, this is never to replace any part of training, first and foremost. Okay. So when you've got the registrars coming through, of course, without a shadow of a doubt, fundamental first things they do is learn how to hold a camera. Okay. And they learn how to hold the camera for half an hour or 4 hours, depending on the procedure. And they've got to learn how to move the camera. That is critically important. Where we see this assisting in the training pathway is when that registrar has mastered the skill of holding the camera. Well, maybe if they're in their final year or two, to be there holding the camera, because they know what they're doing. So give it to a robotic arm and let them get more involved in the physical procedure, maybe some more dissection or whatever it may be. And the same would apply to retracting. Of course, a registrar has to learn how to retract something from day one, and they've got to do that for a long time within the training. But after X period of time, whatever that X may be, they can do that with their eyes closed. What they're more interested in doing is learning more in-depth part of the procedure, where potentially you can allow them to do that, looking over their shoulder, knowing full well that the camera is safe and it's fully controlled and the instrument is retracted, and do the, dare I say, more important parts of the procedure, which is the fine dissection and etc. So no, we're not here to try to black out and change training pathways. Absolutely not. In fact, the complete opposite. We're here to actually enhance that when the time is right. I don't know if that helps from answering your question perspective, but.
Well, I mean, it doesn't, but I know that this is very difficult for you. Robotic surgery, as it is different because, well, certainly for the UK, you don't get to train on the robot until you are an accomplished endoscopic surgeon. So you see, a lot of our robotic surgeons are actually consultants or senior registrars in the later stage of their training. So they have your system as the sort of things that managers in my hospital may actually jump at because they want to be able to put the registrar and SHO in the clinic and on labor ward. And they say, oh, Mr. Ola, you got that robotic arm to number one assistant and robotic two assistant. Only those trainees will not get signed off in 5 years or 7 years because they have actually not yet been trained. And one thing that you probably don't know about, private practice in Nigeria, which if you take somebody's money, millions of naira to operate on her, you do not have any moral right or professional right to hand that to a trainee. And in the NHS, you are not allowed to actually not be scrubbed at the same time as your trainee, even if your trainee is in the final year, final month of training, you still have to be scrubbed. He's no longer allowed to stand behind him on scrub and say, now you take over and work with the robot. This is why I said it doesn't really answer the question, but I understand it's a difficult issue for you. And I only raised it so you can be prepared next time you are addressing an audience, because we are going to be thinking, I don't want a system that would deny me the opportunity of training people who are going to take over from me, people who are going to be working with me.
Well, I think the majority of, so my presentation was in two halves. It was more to explain about the features of the robotic arm, but what's coming next is the exciting part where you have the new version of laparoscopic instrumentation, okay, with a great deal more dexterity than you currently would be using day in, day out. And they're going to be working in combination. But here's the thing, I don't know if you're aware that statistically, it's much easier for a surgeon who does open surgery and very little experience in laparoscopy to jump straight into robotics. Okay, so there's a big problem. I think the robotic companies are developing themselves because when you move surgery, because open surgery is way more like robotics, okay, than it is laparoscopic. Because when you're doing robotics, it's like you're actually inside the patient in there with your physical hands. If you're akin to something like a Da Vinci, which will be very similar to our wrist-X platform. Now, there's a lot of surgeons now that jumped out of that, cauldron of learning laparoscopic, which is really difficult. Okay, we all know that. And they leapfrogged into the field of robotics, which makes a average laparoscopic surgeon seem a lot better. That is an industry commentary that you hear everywhere. And I think that's a problem, because when you convert a robotic procedure to laparoscopic, there's going to be a vacuum of experience there, because surgeons ordinarily, historically, would have done laparoscopic, I agree with you, and then moved to robotics. But now they are leapfrogging straight over laparoscopic into robotics. And I think that's a problem, because if you have to convert off a robot, you would ordinarily think you convert to laparoscopic, but sometimes you're not going to have that beauty. You're going to have to then just open the patient, which isn't good, if you have the opportunity to carry on minimally invasive. So I do get your point, but I say ours is not in any shape or form here to change or increase longevity of people's training pathways. It's here to assist with shortages of surgeons, which is affecting, I don't know, it may not affect your country, but it's affecting most parts of the world. And also to, give a little bit more flexibility to offer, when those staff shortages are apparent, or increase the ability for some trainees to become more, and maybe potentially accelerate their training in a bizarre way, because they can get more involved with the physical procedure. But again, countries differ with the regulatory pathways of that training. So I'm not an expert in your country.
Yeah, thank you very much. Professor Kondo's, yeah.
Okay.
Thank you very much. Professor Kondo's videos were very, very interesting. Most of the videos that I saw, I was distracted a few. Most of the videos were laparoscopic videos. And the dexterity, the amazing dexterity demonstrated, shows exactly what I'm talking about. It's actually quite difficult to know who is the surgeon and who is the assistant in those videos. And this is what we're talking about training. And that is where the bulk of training occurs, where you're working with your assistant and you're getting them to the level that you yourself were when you started as a consultant. Thank you very much.
Can everybody hear me?
Yes, please.
Yeah, I've been trying to talk for some time, but I think there was a communication issue. I know. Okay, so my take on it, I think from the robotic arm point of view, I feel that this is the future, and training will have to adapt to accommodate the future. I don't necessarily feel that outcome is going to be different in the future. I understand Dr. Ola's concern, but the robots are here to stay, and I think that we will have to adapt to them and understand how we're going to evolve the training to incorporate the robots into our practice, or the training of the juniors into our practice. From our colleague from Brazil, I think, is it Dr. Bonjo? Dr. Kondo, sorry. Dr. Kondo. Yeah, Dr. Kondo. I think it's an extreme. I love his videos. I love his dexterity. I think the question for me, and I think this will be very important to our association, is that can he just tell us in very, very quick way how the training got him to where he got to, in terms of how do they train their gynecologists in Brazil to be involved in bowel surgery? Is it something that you have to train as a gynecology first, or they incorporate them into gynae training? I just wonder whether I can just use a few minutes to explain that, and then maybe that will impact on a lot of our members how to approach this moving forward. Thank you.
Thank you for the question. In fact, during my training, I did first general surgery training for 3 years, and then 3 years of OB-GYN. And then I did my fellowship in minimally invasive gynecologic surgery outside the country for 6 months. So I did both gynecology and
surgery.
General surgery.
And it does show.
It really shows.
It really shows. So thank you for sharing your skill. Thank you very much.
Dr. Adebayo.
Dr. Kondo has not addressed my question.
Oh, really?
Yes.
Yeah.
My question.
Yes,
Yeah, we had a
your question is still pending.
we had a question in the beginning about pelvic surgeons. Um, we do share some the same impression. That's very important to train the gynecologists in order to try to be the complete here in Brazil, for example, for pelvic surgery, not in gynecology but oncology, we have two possibilities to reach in oncologic surgery. We can go from a gynecology point of view, so doing gynecology and then afterwards gynecology oncology. And also here we have another way that we can do general surgery, 3 years, then 3 more years of oncologic surgeon. And after oncologic surgery, some of the surgeons will go for pelvic surgery or gynecology. Of course, the skills for all different types of surgical procedures in the abdomen are much more trained following this way through general surgery and surgical oncology. So, but these are the ways for oncology, not for benign disease. A lot of gynecology oncologists now in Brazil are focused on endometriosis because of their training. As there is this lack of training for the gynecologists who do minimally invasive. This was one area that was just picked up by these oncologic surgeons. So, of course, one thing is to manage the surgery. Of course, we as gynecologists, we can train our skills for surgical treatment, but also it's very important to remember about the functional aspect. Of course, the functional aspect of reimplantation or some types of evacuatory disorders. Of course, they are much more well managed by the specialists. So at the same time that we share the same thinking of having a complete pelvic surgeon, of course there is this problem to manage the functional aspects and also the complications of the surgical procedures, because as the complication rate is not high, even the specialists they do not have a higher experience with complications. So I think it's very important to build a team, and it doesn't matter if it's the gynecologist who is the most skilled, who is going to do maybe the procedure in the different area, the different specialty. Because sometimes, for example, the urologist is not well skilled to do a laparoscopic reimplantation. Sometimes they do much more by robots than laparoscopy. But it's very important also to have the colleague in order to share responsibility and also manage some functional aspects, which are very difficult to learn, because one thing is learning surgery, the other thing is managing functional complications or surgical complications. We even being able to perform the surgical procedure, of course, we need also the collaboration with the other specialties. And talking about the complication, our rate of complications is quite low. We have less than 0.2% of dehiscence or fistulas for discoid or shaving procedures, and for segmental, I think we have around 1.2%. Most of them low anastomosis. That's why we try to prefer, if it's possible, to do a double discoid excision. And we have some complications with high anastomosis. In the past, we used to do for the sigmoid nodules, we used to do laparoscopy preparation and a mini funny steel in order to do an external segmental excision with manual anastomosis. It's not a difficult anastomosis. We used to do this in order to save rectus sigmoid, especially for those nodules much higher from the anal, like 25 centimeter from the anal verge, in which we do not. It's not possible to do the excision and reach with the circular stapler if we do just a very small segment. But we had like 4 or 5 complications, fistulas in these cases, and we stopped doing this type of procedures because at the same time that we try to save bowel, we also try to minimize the size of the incision. So usually the anastomosis is not very easy with a small funny steel incision. And we had this type of complications in some patients. Now we try to much longer segment and to use circle, because the anastomosis is more uniform, and so we have complications with manual anastomosis for sigmoid, like 4 or 5, and some complications for low anastomosis.
Thank you. Dr. Akintobi, I hope he's answered all your questions now.
Thank you. Well done.
Dr. Adeba, you have something to say? You have a question?
Yeah, thank you very much, Aegis and the presenters. Great presentation. Thank you for making it this day. I have a question for Dr. Kondos. He said that they used to perform oophorectomy in cases of endometriosis, especially for those who do not desire infertility. And I just wanted to find out, are there other factors to consider before performing oophorectomy in such cases?
Sure.
The other question is for Mr. Collins Eke. I know many of us will have it in mind to ask that question, but somehow it's a social one. Just to find out whether you have any affiliation to Nigeria in any way.
Yeah. It's on the chat box.
It's on the chat. Slogan.
All right, thank you. All right, thank you.
Well, talking about oophorectomy, of course, we always select which patient will benefit from cystectomy or oophorectomy. The thing is that if the patient does not want to conceive anymore, one of the most important things when we try to manage endometrioma is taking into account the risk of recurrence. So, of course, if the patient has bilateral endometriomas, usually we discuss the possibility of doing cystectomy or oophorectomy, but if we do lateral oophorectomy, of course, the patient is going to go into menopause. So if there is a patient, for example, who already did 2 trees for ovarian endometrioma, maybe going to prefer to do bilateral oophorectomy and take hormonal replacement therapy, then having the possibility of having another surgical procedure after the 4th surgery. When is the first surgical procedure? Especially if the patient has unilateral endometriomas, we discuss, and the patient maybe is going to be submitted to hysterectomy. We always discuss the possibility of doing oophorectomy in one side and keeping the normal ovary, because in this way we do not keep them on medical treatment. If the patient prefer to do hysterectomy and cystectomy, we always that there is a very important need for keeping medical therapy after the hysterectomy in order to reduce the rate of recurrence for the endometrioma. So the thing is that we discuss and try to individualize, especially according to the patient desire for keeping or not a medical therapy, but hormonal therapy or contraceptives. But of course, when we discuss this, it's much more important for patients with unilateral disease than bilateral. When there is bilateral disease, almost always the choice is going to be bilateral cystectomy or unilateral oophorectomy and unilateral cystectomy plus contraceptive in the post-op session or bilateral oophorectomy and hormonal replacement therapy.
Thank you.
All
Dr.
right,
Lale,
thank you.
all right. I saw the hands of our vice president up at a point in time. Dr. Olale, you still have something to say?
Yes, thank you very much, Dr. Kondo. And I would just like to come from the angle of the team approach to your style of management of surgery, because I remember when we were at Keregoya, you came with your own radiologist, and also and you came with your assistant, and we had a rich time, a very educative time, understanding the importance of radiological evaluation before going to surgery and the role it has to play in surgical planning as well. So I just wanted to say that just to lay the template. Now, the main thing I wanted to find out this evening is when it comes to the use of the circular staplers, which I saw you're very, very good at using. And, I was actually thinking it's something I could step up to use as well. But how do you determine the sizes? I know there are different sizes. There's 27, 29, 31, and all that. For the linear staplers, they're pretty straightforward. But when it comes to the use of circular staplers, I'm more interested in knowing how to actually plan to use them and use them well. I'm happy. I also learned about the vaginal route of repair as well, and also the advantages and disadvantages that you've stated. But I'm quite interested in the use of circular staplers because we had a lot of this in Keregoya a few weeks ago, about 25 of them, and we had to use a lot of those circular staplers, but I really need to have a better understanding on how you determine what sizes to use, and perhaps what route of repair, what route of anastomosis as well is this that you decide to follow. What determines that? Is it something you planned before the surgery, or is determined by what you actually meet during the operative period? Thank you very much.
Thank you for the question. As I told, we have a very good correlation between our pre-op and intraoperative findings. So usually when there is a nodule less than 2.5 centimeters, below 15 centimeters from the anal verge, we are quite sure that it's going to be possible to do discoid excision. Quite, because the nodules between 10 to 15 centimeters from the anal verge sometimes are difficult if they are like between 2 to 3 centimeters, because we know that the nodule is not, and our radiologist, he measure not the diameter of the nodule but the retraction. So we usually need to measure the concavity, because this is the most important measure for the size of the nodule. If we do only diameter, sometimes one nodule of 2 centimeters has 4 centimeters because of the retraction on the sigmoid. This is the first concept. The second is that the nodules below 10 centimeters are quite easy to do discoid excision if they are less than 3 centimeters, and frequently it's not difficult to advance a 33 or 34 circular stapler because of the diameter of the rectum. But when we go between 10 to 15 centimeters, sometimes even having like after the shaving, we have a very extensive defect, and we would require a 33 centimeter, a 33 diameter circular stapler, and sometimes there is some difficulty to reach the rectosigmoid junction with this size. So uh, and we know that during surgery, if we have a nodule that comes easily above the promontorium, it's quite impossible to do circular stapler excision. This, even if it's small, either you do shaving or discoid with manual repair, or you do segmental because the stapler is not going to reach, except very small nodules that you can advance a very smaller one like a 29. Sometimes we can just go and try to manipulate the bowel and advance like 16, 17 centimeters far from the anal verge, but it's not easy. So at the end today, with the techniques of nose procedures, which we can manipulate not that much, and there is no big requirement for big mobilization of the proximal part of the sigmoid. We try to do more this type of nose or nose procedures for sigmoid and rectosigmoid nodules, and for nodules below 12 centimeters, if they have less than 30 millimeters, 3 centimeters, most of the time we can manage with the discoid. And the lowest the nodule, the easiest to do discoid, because the rectum accommodates very well the circular stapler. It doesn't matter the size, because the size of the stapler we define according to the size of the nodule. Of course, for very small nodules like 1 centimeter, 1.5, usually it's very easy to use a 29 circular stapler. But for bigger ones, we can fit like a 2 centimeter nodule inside a 29 circular stapler, but you need to shave very well, and you need to adjust very well the nodule inside. It's much easier to use a 33 because if you do not do a very extensive shaving, even if there is some degree of fibrosis, you can even put this part of the bowel inside of the stapler. So we try to decide, and this is the beautiful thing of this type of procedures. Of course, there are the indications, but the state of the art and also the intraoperative decision depends much of the experience, and one needs to try to keep doing this type of procedures and increasing experience, because in this way you can apply much more conservative procedures for big nodules. And that's what we are trying to do for nodules up to 3-4 centimeters, using the double discoid, very low lesions, because they have a lot of benefit of this technique.
Thank you very much. That's pretty clear. I appreciate it. Thank you.
Thank you very much, Dr. Kundo, Mr. Colin Eke. I think our time is fast spent. We're going to be bringing the webinar to a close. Before I ask my Vice President to make the final remark, I don't know whether the President has anything to say, but I want to appreciate the presence of our colleague from our sister country. I can see somebody from Ghana, Dr. Paul Adumako. I can see Philomena Wendy. It's a blessing to have you on our call. Thank you. Over to my President.
Okay, thank you very much. Sincere apologies for joining a bit late. I think mine is probably more of a vote of thanks at this point in time, because time is fast spent. On behalf of the Executive Committee of AGES, let me thank our very special guests and presenters, Dr. Williams Kondo and Mr. Collins Ick. I heard it's Ick, not Icky. Well, for the purpose of today's presentation, you are an Igbo man, so I'll call you Mr. Collins Icky. Please accept that from Aegis for today. We've learned a lot, obviously. Time is fast spent, I agree, but it's been a night evening well spent. And I want to thank you and hope that if we call upon you next time, you honor our invitation to give more talks. So I'm sure there's so much or so many things for us to learn from you. And let me also thank our able panelists, Dr. Joan Labi, past Aegis president. And of course, I'll also add Mr. Bolarinde Ola, who's always here with us. Our great moderator, thank you very much for a job well done. For the participants, I'm sure you benefited from this talk. I can assure you that the presentation will be uploaded to our website for those who are financial members, so you can watch again in case you need to refresh your memory. And for those who have not paid their dues, I want to use this opportunity to please appeal to you to please do the needful. And for those who are yet to join us, please join us as soon as possible. So on behalf of the ESCO, I want to wish you a very great and wonderful working week ahead. Thank you very much.
Thank you, Mr. President. Also to set on the chat box, we can see the contact of Slaughter Nigeria Limited, who also has put in some effort to sponsor this webinar. They are the one in charge of the technology that's Mr. Collins Eck discussed, and their partner.
Please, Vice President, bring the session to an end. Thank you.
So on behalf of Aegis, so much has been discussed, and we thank every single one on behalf of the EXCO and all members. And we look forward to another very refreshing time sometime soon. Please remember what the president has said. You need to be a financial member to be able to benefit maximally from all these events that we have lined up from Aegis. So it's so good to have everyone present, and then we look forward to a wonderful time to be set very soon. Have a wonderful evening and a nice and wonderful week ahead as well. Thank you very much, presenters. Thank you very much, moderator. Thank you very much, panelists, and thank you very much, everyone. Have a wonderful evening, and bye for now from Aegis Nigeria. Thank you.
Thank you. Bye.
Thank you very much.
Bye. Thank you.
Thank you.